And so, yeah, I don't know if Dr. Warner still talks about stethoscopes this way, but that's sort of how always wanted to wear my stethoscope when I was a third year, but Dr. Warner did not approve. So, all right. So this is sort of like the end goal of your third year, what I call the third year hike. In a sense, it's quite a view from the top of Yosemite Point, I think. And but I would say that I'm excited for you guys. These third year is also just a great journey along the way. Everybody wants to live on top of the mountain, but all the happiness and growth occurs while you're climbing it. And by the way, COVID did actually really mess up my throat, so I apologize too. So if I start coughing fits, I'm my bad. But yeah, this is Andy Rooney talking about just like, yeah, enjoy the ride or enjoy the hike while you're along the way, and you might see something like this. And so yeah, I think this week has been focused on a lot of different things. I've talked with a lot of your presenters from this week about their talks and try to incorporate a lot of what they're talking about into what we do today to finish off as well. But yeah, I don't know. I just feel like the third year is filled with a lot of growth, and I'm excited for you guys to have that. So, all right. Oh, even before we go on, I'm gonna start with a quick word of prayer, if that's all right. All right. Well, Heavenly Father, Lord, yeah, thank you for these, yeah, third years, Lord. Thank you for the opportunity to get to talk with them a little bit about SOAP notes and workshop presentations and all these things, Lord. But I know that, yeah, they're probably feeling a mix of emotions, excitement, anticipation, fear, dread, just nervousness, all these things, Lord. And I thank you that they're not entering third year alone, but rather that you go with them, or that you also say that you lift up those who are humble, that you don't operate like by the principles of the world where strength and might is how you work, but you also are with the lowly. And just pray that for these students as they just sort of start off the year, pray that you would help them, even if they don't feel qualified or ready or able. Pray that you would strengthen them and help them just to grow and to enjoy every step of the way, God. Thanks for this time. And I pray that you would just help me to have my voice for the rest of the talk. And I just pray that they would really benefit from it. I pray for all these things in Jesus' name. Amen. Okay, all right. So just a couple disclosures. Since I graduated from Loma Linda and did my peds residency here, and I've got to live in both the internal medicine and pediatrics world. I do come up at this talk from a little bit more from the medicine and pediatrics kind of perspective, but I do try to incorporate some of the surgical perspective as well. Yeah, I mostly work in the outpatient realm, but I still work inpatient as well. So I will try, but this talk will be mostly inpatient since that's where a majority of you will be doing some of these presentations. But there's similar concepts for outpatient as well, but I'm just a little bit different. Okay, what's the structure for today? You already had Dr. Tarver give you sort of a clinical applications talk, and hopefully the rest of the day is connected here. So you're going to just talk about SOAP notes and just build upon that, and then we're going to do presentations next. After that, the SOAP note talk will probably take the majority of the morning, and the presentations towards the latter part of the morning. And then, of course, you get to practice in your life communities with with some of the fourth year or still third year mentors as well. And of course enjoy lunch as well. So, okay, so why do we talk about notes? I think actually Dr. No and everyone else has actually sort of had you guys do a little bit more notes than previously. So I think this is actually really good that you guys already have some experience, but I can't emphasize how important it is to just be able to write notes to be able to communicate with other people. I think like in practicing for this talk, I mean, I've given it the last few years, like just saying it in my mind, since I'm trying to save my voice for today, is different than me just actually talking to you right now out loud and trying to actually get across what I have in my mind in a sense. So notes are just ways to force us to actually put down what we're actually thinking. Of course, you get to document and you bill for services. Starting this year, Dr. Jones may have already mentioned, some of your notes are going to start counting, which is, when I went through med school, my notes did count. It made a huge difference, and I'm excited that you guys will have some of your notes count. And that just helps it be, yeah, people will bill off your notes in a sense. So it'll help you remember. That's for me, because I can't remember a lot of stuff for my patients, and so writing good notes helps me remember. And then of course, when you write a good note, you can present it pretty well, which is why we're doing this SOAP note workshop first, and then we're going to do the presentations workshop, because the note you write during this workshop, you're going to actually practice it as a presentation later on in your small groups as well. So, but hopefully just, like, even if your notes aren't going to count for some of you, like, you're going to, it's just a great tool and ability to learn and to, yeah. So what kind of notes are out there? History and physical notes. You may have heard these, like, H&P notes. Even though it says H&P, it actually really has a history and a physical. It also has an assessment. All right. Okay. Cool. No, thank you, guys. Yay. All right. I am talking to somebody. All right. Okay. Yeah, you can, you do these in the ER, you do these in the clinic. Today, we're going to focus on admission to the hospital, or even consultations if you're a consultant, in a sense. So, so there's progress notes as well. These are the daily progress notes you can write on patients in the hospital on hospital day 2, 3, 4, 5. There's some transfer notes and discharge notes. We're not going to focus as much on the transfer and discharge notes today, but where do SOAP notes fall? I mean, SOAP note is everywhere, because it's actually sort of just, it's more of a template and style for your note, not an actual note type, if that makes sense. So all these notes will have SOAP in their way, right? So SOAP notes are really a format or outline and how you write the notes, not an actual note type. Hopefully that makes a little sense when I do this, like the 5-paragraph essay you grew up writing with, right? So intro, body paragraph 1, 2, 3, and a conclusion. So yeah, so it's more like there's lots of different kinds of essays out there, but the format here is sort of like how we start off this way. All right. Hey, everyone. All right, cool. Okay, all right. So yeah, so SOAP note is an outline of how you write your note, regardless of what kind of note it is. And so just some multiple choice, your first multiple choice test of 3rd year. Hopefully you get this one. But okay, focusing today mostly on initial H&Ps for admissions and daily hospital progress notes, right? There's so many other notes, but I think just those two notes are probably going to be the majority of the notes you're going to write this year, in a sense. And since you guys have focused a lot on being able to ask history questions and do physical exams, more focused on the clinical reasoning and the assessment and plan portions. You had Dr. No and Dr. Chandrasekhar sort of talk about clinical reasoning. And so as you do the clinical reasoning, as you're trying to write it down, what does it actually look like? Is sort of like the assessment and plan portion here. Okay, so all right. Let's see. So why are you doing SOAP notes? I think you already practiced clinical reasoning, and then you just want to know, how does this translate practically in a sense? And so that's why we're doing this talk here. And I also know that there's not as much formal teaching, because you just haven't been doing as many notes yet. So, okay, so just an example here, subjective portion of your note. How are you guys feeling this morning? If you had your coffee yet? Are you nervous about starting 3rd year? Those are all questions. And so when you're asking these questions, this is sort of what you put in the subjective portion of your note here. Objective portion, maybe not 170 there in that room, but hopefully no 1st and 2nd years there. Room temperature 72, and it's very painful right now. So these are all the objective portions of your note that you're going to put in the O portion of your note. Your assessment might be 170 medical students who are bright, starting to understand they're about to start working long hours, only go home and study some more, right? And that might be exciting for some, woohoo, fearful or tired in a sense. So, but you'll notice there, like assessment portion, the reason I put this portion right here is because that's the portion of your note where you're going to actually be putting your differential diagnosis of things there. So, okay, some people are like, where do I put that? All right, your plan portion is sort of like always action oriented, what you want to do, and then go from there. All right. Okay, so I just a random life hack here, but I think you enter 3rd year going, I'm going to be a student in a sense, but I really feel like whenever I'm on wards, I really enjoy when the students are actually teaching as well. And so like if you go into every day going, I'm a teacher as well as a student, that I have something to give in addition to something to receive, I think your 3rd year is going to go really well. So, okay, and you have a lot to offer, trust me. Okay, so let's get to the crux of the talk today, which is a case presentation here. So the best way to learn how to write notes is to practice writing notes. And so we're going to start with Mr. S. And so yeah, let's say you're on internal medicine. I know only like 30 of you are, but you happen to be on your call, your very first day, lucky. It's Monday afternoon. Let's say it's this Monday, May 2nd at 5 p.m. Your team gets a call to go to the emergency department to admit Mr. S to the hospital. All right. Okay. So the first part is, ID and chief complaint. An 86-year-old male, history of hypothyroidism, presents with 1 week history of throat pain. All right. So let's say, since you've been practicing history skills, this is the history you get for him. Right throat neck pain, it's going on for a week, constant dull, worsening pain, 9 out of 10. It sort of radiates to the right ear into the nose. He's got to try some over-the-counter medications without real relief. And so have I been trying over-the-counter medications without relief. Pain worsens at night, has more difficulty breathing, some more difficulty swallowing water than solids. He's losing his voice for the last month, but it lost his voice completely 2 years ago. Imagine, this is actually a real patient for my residency, and trying to get a history from him was actually sort of tough since I couldn't hear him. And a 40-pound weight loss in the last year. He's got a productive cough. He's got review systems is negative for those things, and his primary care doctor did refer him to ENT, but since it's sometimes tough to get into a specialist, he hasn't been able to go in there yet. So you'll notice there's the 7 dimensions here, some associated symptoms, and then a review of systems. So this is sort of part of your HPI and a review of systems here. I know that I went through that sort of fast right there, but you'll have a chance to actually look at this a little bit more closely in a sec. His other history, he's got hypothyroidism and sinusitis. He's had hypothyroidism for a long time. He's had an appendectomy. He takes only 1 medication, levothyroxine, 15 mics per day. No known drug allergies, no family history. In social history, he did quit smoking 6 to 7 years ago, but did have a 70-year smoking history. He's retired, denies any alcohol or other drugs, and prayer is what keeps him going through tough times. All right. Okay, and that's just a quick plug there in terms of social history. I think like internal medicine will teach you how to ask what matters most to your patients, and I think that's a great way to get to know your patient as a whole person. All right, on physical exam, you see him in the ER. These are the ER emergency department vital signs. He doesn't have a temperature. His heart rate's up a little bit, but not by much. Respiratory rate is 20, and blood pressure 115/78. He's setting 98% on room air. He's 9 out of 10 pain in the right neck. All right. So you go on to your physical exam. You've been practicing clinical skills lab for a while, so you've done the whole exam. Really, unremarkable. Like HENT exam, other than he's lost his voice, can't speak to you. His lips are dry, but his heart's regular rate, and lungs are clear, abdomen soft, and extremities are intact. So you do your neck exam for him. He's got tenderness over the right neck. No lymphadenopathy though. His thyroid exam's normal. You do see some drooping on the right neck skin, maybe some swelling or something like that going on there. All right. Okay, you get some labs on him, or at least the labs the ER has already got on him. I've drawn a couple of fishbone diagrams here. These are like the 2 most common things to order all year, and so like this is sort of how some people might use shorthand. But don't sweat it too much if you don't know what those are, just in case you see those down the line. But if you look at I didn't include his whole complete blood count, but let's say his white blood cells are down a little bit, hemoglobin's down, and his complete metabolic panel, for the most part, is normal. These aren't all the labs for this CMP either, though. And he's got a TSH and a free T4 that are obviously abnormal. Okay. All right. Okay, you get some imaging on him. He's got a chest X-ray, and it's negative per the resident read. Remember, it's 5 or 6 o'clock at night now. There's the attending radiologist will be back in the morning to read the final imaging. But for right now, the residents are reading it, and the CT soft tissue neck with IV contrast, no neck tumors, masses. He's got a little calcification in his left thyroid gland. He's got some sinusitis going on, just chronically, and but nothing else there. All right. So, so this is, let's say you're down in the ED, you've asked the questions, you've done your physical exam, you've reviewed his labs and his imaging, and this is sort of where you're at. Okay. So you have your subjective and your objective portion of your note sort of done here, in a sense. This is what you would write for this your subjective objective portion of your admission history and physical. But that's our focus today isn't on this part of the SOAP note, right? It's actually on the assessment and plan. So if you earlier on you weren't able to access the QR code, you can just, this is the same QR code as the beginning, but now I'm going to have you go ahead and download the SoapNote workshop worksheet with handout for students. There's a PDF and there's a Word doc, just more like, because you're going to be writing here. So you can either type or use Notability, however you want to do this. So whatever PDF or Word doc works out best for you there. So, all right. I think I'm looking at everyone sort of like downloading that in a sense. So it's a 10-page worksheet. And we're just gonna work through our way there. But you'll notice the very first page on there actually just has what I just put up there on the screen for you guys there. So, okay. And all right. Anybody with any issues finding that? Everyone's good. Okay.
Can you hear me all now, Dr. Wei?
I can hear you now. Yes.
Oh, yes. I think I fixed it.
All right.
You can hear us.
Cool, cool. Nobody has any issues? Just want to make sure you guys have.
I think they're finding. I'm put this right here.
Okay. All right. Well, I mean, we're gonna just practice some stuff. So if there's any issues while we're practicing, somebody can just come up and talk with me about it. But all right. So you'll notice. So the first thing you're gonna do is actually develop a problem list. This doesn't always. I guess this technically does show up in your note, but this is something Dr. Knows probably talked to you guys a little bit about. But it's really just listing out the problems that you can find. And that will allow you to sort of start then like, okay, I have all this in front of me. How do I then put it together into my assessment and plan, differential, all those things. So problem list can sort of include things from your history, whether it's from symptoms, it's past medical history, social history, some of those things, any physical exam findings that are abnormal, any lab findings that are abnormal, or diagnoses that are abnormal. So, so I'm actually going to give you like 3 minutes to write out a problems list. Just on your own, and then we'll sort of come back together. All right. So I'm always trying to balance the fact that some of this might be simpler than for some people and harder for other people, and that's okay. But hopefully you had a chance to write down some things that you think were on the problem list here, and there's quite a bit of things from here. So I'm actually just going to show you guys a sample problem list here that I may have found. It doesn't mean that I have everything here, but here's a problem list that I came up with. So maybe from your history portion, you might say, okay, a problem might be neck pain or throat pain, some dysphagia since he having some difficulty swallowing, dysphonia, or aphonia if he can't speak in a sense. He's got hypothyroidism, that's from his past medical history. He's got weight loss, and that's also from his current history, and then his 70-pack year smoking history, that could be a problem as well. He's got on the labs, he has some anemia, he had some hypothyroidism, he had some leukopenia. You can even put here that he had hypothyroidism on there as well, because we got his TSH and free T4 that were wonky there. So, okay. So hopefully that gives you an idea of like, okay, this is like, so whenever you like just take a history and do a physical portion, then you just, okay, what are the problems here? And once you have this in front of you, it will help you to start going, okay, now I got to start organizing it into something for the actual assessment plan here. So, all right. So yeah, so I'm actually, now, remember, it's still Monday evening, you're still writing out your history and physical admission, history and physical, and you're writing assessment and plan portion now. So I'm going to give you 8 minutes to write that. It should be on page number 3 of your worksheet where you can start to type or write there. And this is the part where, you know, like you might go, oh, I don't really know what to write here, or I don't know much about dysphonia, let's say. That's the part where you might go, okay, I can use Dr. Tarver's clinical applications to maybe look up Dynamed, UpToDate, some other stuff like that to help you sort of write out your plan for that. But for right now, don't sweat it too much. We're going to keep it simple here. So just go ahead and write out your assessment and then your plan, and then we'll come back together. So I do, I think I hear you guys talking a little bit. Yeah, feel free to actually just do it on your own here, because actually you're gonna have a chance to share with your partner in a little bit, but I do want you to just have like a little bit deep work, deep focus time to be able to write out all the things that you think are part of the assessment plan here, because there's a lot of parts here that I want you to be able to cover. All right. So hopefully you guys all had a chance to write down some stuff. I think part of this is actually just being able to see what other people do as well. So I'm actually going to have you guys take about 4 minutes and go ahead and share your assessment plan with your neighbor and just sort of like compare and contrast what you guys have and just sort of, oh, they put this, I didn't know I should do that. And then we'll come back together and we'll actually look through some of these. If one or two of you wouldn't mind emailing me with your assessment plan, I might just throw something on the screen and we might review it just so everyone else can see it as well. I'm not gonna put your name out there or anything like that. So if you just email me at that with your assessment plan while you share, I might be able to put a couple up. So, all right, we'll come back together. 4 minutes.
Do all of you have Dr. Way's email? Can you find it? Andrew Way, W-A-I.
Hopefully you can just see it on the screen right there.
Thank you, Dr. Way.
Because I was thinking of like CT reveals complications. Maybe right. We should say all that. Okay, so all.
All right, so I'm gonna go ahead and bring it back together here. Let's see. I think I saw like a silver balloon out in the crowd. And I was like, oh, someone's birthday or something like that, right? So, okay. So hopefully, yeah. So what you may have noticed is just like if you were trying to verbalize your assessment and plan, it sometimes feels a little bit different from what you're writing and what you're communicating, and that's part of like the struggle of third years. Like I can put something down, but I don't necessarily want to say it out loud that way. So we're gonna obviously practice that a little bit more, but hopefully you got to see a couple different, like someone else's style for writing that. And I don't think I got one, which is fine because we're actually going to go over sort of the assessment plan that one example of it here. So, all right. Okay. So here you go. So here, maybe like if you're trying to write the assessment plan, assessment portion of your plan here, or if you're A&P, you might say, okay, I have an 86-year-old male. The history of hypothyroidism presents with 1 week history of right throat pain and dysphagia, along with 2 week history of dysphonia. So here you might say, what are some components here? You got the age, you got his history, and then maybe what he presents with. The tough part is he presented with a lot of stuff, and you're trying to present sort of like what you think his main thing is here. And so his throat pain is clearly what he's complaining of in a sense. And so oftentimes that will go there in addition to some other things that you're like, oh, that's a little bit concerning. So that's your assessment, like one-liner. Some people might call it like sort of a problem representation. And then you're like, okay, well, I haven't actually given a diagnosis here, right? Like your assessment is, these are just a bunch of symptoms I put out here. You're trying to actually come up with the actual diagnosis. And so here you might say, okay, I'm going to put a differential diagnosis And because if you don't know what it is, that's when your differential is included here, right? Like you don't need to put a differential if you already say this is blah, 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 in a sense. But here you're like, I'm not sure what this is from, but maybe my differential includes number one, malignancy, since he's got a 40-pound weight loss, 70 past year smoking history, he's got neck pain, he's got dysphagia. You might say like, this is the most likely differential. So you'll see like, number one, you order your differential always in the order of most likely. And then you're also putting your justification. What are the pertinent positives or pertinent negatives that make you think of malignancy based on his history or physical kind of things that you've asked, all right? So maybe, but he could have an abscess as well. Maybe it's because he has some swelling, it's subacute, he's got pain. Maybe he's got just severe hypothyroidism. Let's say I went on Dynamad real quick and looked at, well, severe hypothyroidism can cause dysphonia. I didn't know that. And so you might say that, and then maybe he's got some recurrent laryngeal nerve injury. I just put that in there just because anatomy is just bad memories, right? So, but yeah, maybe like, it causes him dysphonia, but you don't remember that this recurrent laryngeal nerve injury causes dysphagia, so that makes it less likely in a sense. Okay. All right, so you see it like that's an assessment for your initial history and physical, especially if you don't have an actual diagnosis down here. All right. Yeah, so this is actually the most important part of your note as a third year, right here. This screen right here, if you can do this part well, people will go, okay, you are well on your way to doing things well, because this is where you're putting all that information and data together into something that is succinct and something that you actually think is going on. So when we practice the presentation portion of your note, most people will think, like I just need to get all the details right. I need to make sure I communicate like the vitals correctly and all this other stuff. But most attendings will be listening for your assessment. They will sort of like half listen for everything else because they've already reviewed everything as well. But they want to see not only can you report data, but can you interpret data into something coherent here, right? And this is the clinical reasoning part. So yeah. All right. Okay, so now you've done your assessment. Now let's actually go to the plan portion, right? Like, what do you actually want to do? So what's interesting here is like, oftentimes when you have a assessment, there's the overall like one-liner assessment with differential, but then like you actually have an assessment, like a hashtag here for like, each of the problems, like a right throat pain with dysphonia might be a problem here, right? We don't know what it is, but we know he has this. So you might say, once again, this might be a little bit redundant because you already sort of mentioned some of it above, but you are trying to provide justification here for what this thing is right here. Okay, maybe it's like, okay, most likely malignancy because of all these things. All right, so that's your sub assessment or however you want to do it, your hashtag number one. Hashtag number one always is your most important thing. That's not good. Okay, and then your plan, right? So here you might say, actually, wait a second, I already have a CT soft tissue. So maybe you might say follow up CT final read for CT soft tissue neck with IV contrast, because right now it's just a resident read. Of course you want to make sure he doesn't have any more pain, so you hook him up some IV morphine here. So that's the plan portion of for this assessment. Cool. But you've also realized actually we're now going to all the individual problems. Hopefully you did not stop your note just with the right throat pain, because clearly he's got other issues going on here that you have to be able to address. So you move on to hashtag number two, he's got hypothyroidism. All right, so you realize, hey, on labs, he had some subtherapeutic thyroxine levels, his TSH was really high, but maybe it's not really acute since he's been hypothyroid for 50 years and he's been on the levothyroxine 15 micrograms for a really long time, so I don't know. But you've also noticed severe hypothyroidism, like as I already mentioned earlier, can be possible cause for dysphonia. So that's your assessment plan portion here, again, and then you have your plan. Okay, maybe I'll increase his levothyroxine to a higher dose so I can sort of be able to help fix some of this. Maybe I might look at his, I only have his one TSH and T4 level. Maybe I need to get outside labs for that. And maybe I'm like, maybe something is up with his thyroid. Like if I'm saying malignancy, thyroid malignancy might actually be something to consider here. And so maybe I need an ultrasound or final aspiration. I realize I'm saying all this in front of Dr. Cardenas here. You can totally correct me if I'm wrong here, but I was just a resident. So, okay, still working on my assessment plan. All right. So that might be problem number two here. Problem number 3, you might go, "Okay, well, I did notice he's got anemia, right?" And once again, if you're looking at how did I come up with these hashtags, you are just looking at, well, look at these problems that you already wrote out here. So you have a hashtag that sort of incorporates a couple of these, hashtag incorporates this, a hashtag that has this. So your fodder for your hashtags are probably going to be things from your problem list here. Okay. All right. So maybe hashtag number 3, he's got anemia. You're always trying to put like maybe why he has it. Does he have anemia of chronic disease? Does he have acute blood loss anemia? Or iron deficiency anemia? Like different things. So you're trying to put your justification for maybe what kind of anemia he has here. You're like, okay, well maybe like I studied a lot of past first thing you're supposed to get iron studies here to see if he's actually low in iron. I just facetiously put in continue to monitor here because if you don't really know what to write, sometimes people just write that. You don't have to write that at all. Like you don't need to fill in space. You don't need to make your progress notes longer. If anything, everybody wants your progress notes to be shorter here. So, okay. All right. So you might be going, oh yeah, I didn't include some of these things, and that's okay, right? Like you struggle through writing a assessment plan. We're actually going to go ahead and practice some more coming up, but every progress note will have a FEN and prophylaxis portion as well. And this is, I don't know, just a hashtag I put in there, but like essentially, everybody's got to get some sort of nutrition somehow when they're in the hospital. So you might have FEN portion, fluid electrolytes nutrition, and prophylaxis. So you might say, okay, let's make him MPO for now. Start some IV fluids on him. And these are the fluids I want to start on him. Maybe some D5 half NS at 100 mLs per hour. And I'm going to put him on some heparin for some deep venous thrombosis prophylaxis. Okay, so everybody will have FEN prophylaxis hashtag. And then I personally throw in a whole person care hashtag in there, sort of like because it helps me remember, hey, like what is it this person like cares about the most, or what matters to them most, or for this guy, he's obviously scared, but being here in the hospital, and prayer is something that keeps him going through tough times. So I actually will write down my note that actually I offered prayer and that patient found it helpful or was receptive to it in a sense. All right, so all right, and then lastly, this one I think is actually really helpful as a third year is the disposition, which is like what is ultimately going to happen to this patient. For right now, like you're admitting the patient to the hospital, you're going to admit him to one of the teams, but later on you'll see like disposition is like, how do I get this guy home, or this patient home? And so if you're always thinking about that, especially when you admit them to the hospital, what's the things that's going to get them home, you're going to be well on your way to be doing well as a third year as well. So, okay, all right. So this is your SOAP note, your admission H&P in one slide right here, right? Clearly, this is a lot of stuff right here, yeah. So it's more like, oh, you can. I know I made it look really easy, but you're going to be able to write these, and the more you write these during third year, the more like you're going to be prepared for everything else. So I will be honest, depending on your rotations, you may not actually get a lot of opportunities to do this. And some of that is dependent on a lot of different things. But for me, like I think if there's one thing you can do to grow the most as a third year, is to write an admission history and physical note. So every opportunity you have to admit somebody to the hospital and write a SOAP note that's an admission H&P, you're gonna just grow a ton in that way. So okay, and that's my big plug, more because like when I talk to students, they're like, I actually haven't written that many of these, and I'm like, oh, okay, it's gonna be harder for you down the line because when I first started doing this, it took me about 3 hours to do this, right? Like it takes a long time, and so you just got to do it again and again and get it down to a faster level. So by the time you're a fourth year and a resident, you can do it much faster than 3 hours. But I was slow and it just took me a long time to do this. All right. Okay. Sure. Any questions on the admission history and physical? Yes. I might have to have Dr. Corners either do a mic or just repeat the question.
So Dr. Wei, they were wondering, what does the 2/2 mean? So secondary short hand for secondary, correct?
Oh yeah, likely secondary, like right down here, likely secondary to possible malignancy. You're right. I apologize. There's lots of shorthand here, and abbreviations, but that's, yeah, secondary.
Because they will see that a lot. And it's because we can't write the little, circle in the superscript. So we do
Yeah.
2/2, secondary 2.
Yes. Yeah. Nope. Yeah. You're gonna see a lot of shorthand, and I apologize that I didn't make that clear. So
Good point. Ask questions and don't assume. Yeah.
yeah. So asking questions at the right time during third years can sometimes seem daunting. I'll be honest, because you're like, oh, am I supposed to interrupt something and ask something? But like right now, definitely ask away. And then also like, that's why you have a lot of other third years and like the residents with you. And sometimes you might write the question down you want to ask and ask it a little bit later, because rounds is always a fast-paced thing. Yeah, definitely do make sure you get to ask the questions. I saw another one in the back.
And probably, right, Dr. Wei, the first person that you would ask is your senior student that may be on the team. Then they don't know, right? Because the student, if a senior student or a more senior junior that you're on with right now, they'll probably know what it is.
Yeah.
One last thing, just because we're talking about abbreviations, don't use abbreviations in front of patients, right? So don't say this person has SOB, because really, truthfully, in practice, that's happened, right? Short of breath, that's what you mean, but a patient may actually think something completely different. So it's happened. That's why I say it.
Dr. Rose brings up a really good point. Like each time I'm with my team, like I always say, like we're going to talk medical jargon. Where we're practicing today is a lot of medical jargon portion. But when you actually are talking to patients, it's just a whole different ballgame. So you can't update patients the way you talk to your team, and that's okay, right? Because like that's you learning like, okay, I need to be able to speak medical jargon here, but then I need to bring it down to the level of my patient and really understand, like make sure that they understand it. And that is a hard art right there. So was there one more? Way back right.
Another question? Yes. So Dr. Wei, how would you apply nutrition for this patient?
How would I apply nutrition? Yeah, so maybe initially in the hospital, like you're just giving them IV fluids, because you're obviously starving them right now with MPO, but you obviously can't do that for a very long time. So when patients are first admitted to the hospital, they don't always necessarily want to eat anyways, but you might say, if I was going to make them MPO, I could just give them a clear liquid diet or regular diet, and then you can sometimes get away with fluids for just a day or something like that. Yeah. Good
questions. Good questions for Dr. Wei.
Yeah. No, I appreciate it. Yeah. So please ask away if you do have some more. So, and the cool part is you're going to be able to ask these questions in your smaller groups later today as well. So, okay. What did I just do here? Okay. All right. So we talked about it all in one slide, and okay. So now you finish your H&P. You're like, okay, I'm going to go home and I'm going to sleep, and you come back the next day, right? So you've written the mission H&P note, daily progress note on the second day. They're still both SOAP notes. So it's 6 a.m. on Tuesday. You're like, oh, bright and early, because that's, when you're in the hospital, you're pre-rounding on Mr. S. What kinds of questions would you ask him while he's half asleep? You might say, okay, some questions in the morning. You might ask, how's your neck pain going? How's your eating? Well, clearly he's not eating because we made him MPO. Any worsening or improvement of your voice? Any fevers? What he answers to that is what you're going to put in your subjective portion of your daily progress now, right? Like it's the questions you ask. Oftentimes a mistake I see is like some people will put like, the lipase came back as this. That's really not a subjective. It's not a question you really ask the patient. It's that might actually be in your objective portion of your note in the labs portion. Okay. So let's say you do a physical exam. That's where you're going to write the physical exam. You get some labs back at 7. He's got a creatinine of 1.5 now, up from 0.9. And his hemoglobin is now up to 13 from 8.6. Okay, let's just say those are the labs that come back the next morning. All right, you get a call back from the radiology with an official attending read at 8 a.m. and it says CT soft tissue neck actually says laryngeal cancer in the subglottic area. And you're like, oh, okay. And you're like, oh, that's not good. All right. So now you're like, okay, it's now 9 o'clock and you're supposed to present the patient on rounds. So we'll actually practice this in the next workshop. But this is just to give you an idea of like the context for what this might look. Once again, this depends on your rotation. It might be much earlier in the day if you're on a surgical rotation or something like that. So, okay, but now you're gonna write the progress note for day 2 here. And we've already said subjective. Let's say his pain is improved with pain medications. Subjective, he's got his vitals and physical exam. We already said his creatinine is 1.5, hemoglobin 13. But now we're going to once again focus on writing a daily progress note assessment and plan for right now. And so we'll sort of have you take 5 minutes and write out an assessment and plan for your daily progress note.
Hey guys, I just put on the screen, in case there are questions, and I want you guys to be able to ask questions. I just opened my Slido. I give you my account there. It's sli.do, and there's the number. So you can just write an anonymous question to see if you have. I'll be monitoring that for Dr. Wei. So if you guys had questions in the back and I didn't see you for some reason, that's a way for me to monitor any questions from the back.
Oh my God.
All right. So now that you had 5 minutes to do that, you'll try to see how some things may have changed. I'm going to have you share with your partner again your assessment plan, just sort of see what they may have done differently. And if somebody does want to email me, I'll look at another one. If not, that's okay too. And we'll come back together in a couple minutes.
Dr. Wei, as they're talking and continue to do some work, there was a question: what information does and doesn't belong in the daily progress note? Do you only note changes?
Cool. Well, good news is we are going to talk about that.
Dr. Wei, did you get the question?
Yep. Mm-hmm.
Okay.
Yeah. So I will address that
Okay.
for sure. All right. Okay. So yes, thanks for asking questions. I see that you guys want Dr. Glaucom-Flecken to speak at your graduation as well. So maybe it might happen. So okay. But the question was more along the lines of, is there something that should or shouldn't belong? So we'll actually just practice some of this together and go from there. So okay. All right. So let's actually talk about like these. Hopefully by doing this, you'll see what does or doesn't belong in a daily progress note in a sense. So, and if it's still unclear after that, we can talk about it. All right. So here for your assessment portion or the summary statement, you might have your 86-year-old male with history of hypothyroidism who presents with throat pain, dysphonia, weight loss, now with laryngeal cancer. So you see how your assessment has changed now, right? The previous assessment here, just says, hey, like presents symptoms. It had symptoms and it gave a differential. Now your new one has, well, it might still present the symptoms, but it's unified in a diagnosis of laryngeal cancer. And you no longer need a differential diagnosis because you're like, well, I made the determination it's laryngeal cancer in a sense. Okay, so you see how like if we were still unclear on day 2, you can still have a differential diagnosis, but once you've made a diagnosis, that portion should start changing your assessment. That makes sense. That part's hopefully a big part there. And then maybe on your plan portion, now you have, instead of saying, if you look all the way back up here, we had right throat pain with dysphonia, right? So your hashtags can be things like symptoms, right? But once you can unify the symptoms in terms of like actual diagnosis, you just change the hashtag. And so the hashtag is no longer right throat pain. It is now laryngeal cancer. And you might be able to support that diagnosis in a sense. And but it does explain why there might be dysphonia and dysphagia there as well, and right throat pain. And so your plan changes a little bit. Like, okay, well, this is our time to talk to ENT. We need to do an ENT consult, probably get a fine needle aspiration to try to, get some pathology for the cancer. Definitely going to continue the IV morphine, but maybe I'll get him some speech therapy because we do want him to be able to get his voice back, and speech therapists can help us with that. Or here, more like, I'm not sure if this guy should eat, right? Like when you guys ask question, can he eat? Well, I'm like, the last thing I want him to do right now is to eat, and then he'll aspirate, and then We don't want that to happen. So maybe I need a speech therapist eval to help me go like do actual swallow evaluation, see what he can tolerate eating wise. Okay, do you see how your hashtag has changed now for daily progress note now that you have a diagnosis and some things have changed? Okay, but you're like, oh, do I need the rest of the note, right? Like, is this hypothyroidism still an issue? Well, I mean, it's something that you're still sort of addressing in a sense, right? Like, you might go like, well, now maybe I might need a thyroid ultrasound or aspiration as well in case, hey, like the laryngeal cancer is hopped on over. I don't, like I'm just putting a couple things down here in a sense, but you might say I could just take out this portion. You already had it from the day before, but if it helps you explain some things, you might leave it in. You'll start noticing there's just a lot of this is style and preference and how thorough or how succinct you want to be. But the best way to always start off third year is to be a little bit more thorough and to try to explain each thing that you're doing. Later on, you can start chopping things away, just like your history that you take that you guys are asking. You learn to ask a ton of history questions. You learn to ask like a 30-point review of systems. You don't ask everybody a 30-point review of systems. You start to like ask pertinence after a while, but you start off with being more thorough and then you work your way down. And so when you start third year, just start off being thorough and then work your way down. Nobody's going to blame you for being thorough. Maybe that's just the best way for me to say it. But eventually you should start to cut things down. You just don't need to have it all down right away. Okay. All right, so your anemia, remember his hemoglobin came back as 13 now, so you might say his anemia is resolved. And you might even put a little thing like there, maybe he was, there was a lab error and that's why it was 8.6 initially, or, you can speculate if you'd like there in a sense. But now you also notice he had a new lab result that came back, right? His creatinine bumped to 1.5, right? And you're like, oh, I need to, go like, oh, he's got ACAD, what's that from? And maybe his pre-renal giving me difficulty swallowing fluids. He's just dehydrated in a sense. And so, but maybe I need to get FeNA urine electrolytes to do that calculation or get a renal ultrasound if I'm thinking there's some, maybe an obstructive component to it. Maybe I might put the Foley in him to make sure I collect the urine. I mean, so more you can see how, you see this is a totally new thing that wasn't on your initial H&P. But now that a lab result has come back, you can add this on there. Okay. And then I just wanted you guys to remember your nephro lectures from Dr. Werner, of course. So this is actually a super, super common hashtag right here. Okay. And then going back to FEN prophylaxis, like, okay, we're going to do a speech therapy eval, but now that we're actually going to probably ask ENT for a biopsy of some sort or a surgical procedure, probably going to make him MPO at midnight. That's what MN stands for. And then still some of the other stuff is the same. Okay. So yeah, so you might know it for yourself. Okay, did I include some of these things? Like, did I take off any of these things? Whole person care, like once again, once again, it helps me remember the person. And then disposition here now is no longer admit to internal medicine, but maybe await ENT recommendations after, biopsy or something like that. Okay. All right, so here's your assessment and plan all in one portion here. Once again, your daily progress note will still have your subjective portion up here, your objective with your vitals, your physical exam and your labs for the day and images. But then when you get to your assessment plan portion, this is what some of the things you might write. Once again, this is just one style. Your note might be shorter, it might be longer than that. Yeah, I think the big thing to note there is this, like when you're not sure, you can always put hashtag symptoms like neck pain or dysphonia or something like that. But when you have something that unifies it, you change it to the actual diagnosis. So you're trying to make the hashtags as much diagnosis related as possible and try to explain why acute kidney injury likely pre-renal as opposed to intrarenal or post-renal in a sense. So okay, and then of course you always have your FEN prophylaxis and your whole person care and dispo hashtags as well at the end. All right.
Dr. Wade, do you mind if I just mention something? Because I thought that was really big there. Like on the anemia portion where you put resolved on your daily progress notes, especially when they're in patients, it always is nice to have some assessment of what actually happened from the prior day. So resolved, improving, patient is not doing well, whatever you want. So it just tells the the person that's reading that you're actually writing a note for that day, right? And you're assessing that something has changed from the prior day. So it's really nice. For instance, I write a lot of notes on blood sugars, right? For endocrinology. And so I like to say improving, not improving, resistance going up, whatever it is, just so that the team knows, hey, we're actually, changing the note every day.
Yeah, so good. Consult Dr. Codornes, something like that. Okay, so yeah, so you can see you guys get to play around some of that. Yes, and yeah, actually, you'll notice a lot of people emphasize for the assessment here that this part should change every day as well. You might say now with laryngeal cancer, awaiting FNA biopsy by ENT or something like that. Or after he, maybe the next day after he's had his biopsy, you might say awaiting FNA pathology or something like that. So you can see, like, you can change little things in your note each day. The temptation will just be to copy and paste this entire thing forward, and that will get the note done fast, but you don't really learn a whole lot if you just copy and paste and just sign or something like that, right? Like, you're trying to say, what am I actually waiting for here? Like awaiting, hematology recommendations or hemonc recommendations for, initiating chemotherapy or something like that. So, okay, so that's another big thing. Yes, so using qualifiers like improving, resolved, worsening, and then also changing your assessment each day a little bit. So.
Dr. Wei, I'm sure you'll get to that in the presentation part of the workshop, but there was a question on how do you present? Is it off bullet point or subjective? So I think you'll go over that more in the presentation portion, right?
Yeah, I will do some of that. And we'll definitely talk about that some more there. And once again, I'm presenting some of it's style based, and everybody will develop their own style, but I'm trying to give general principles that will help you out. So yes. Cool, but yes, so that's why. So everything you're writing down right now, like your daily progress note here, and then also your mission, history, and physical, you will have a chance to actually present what you wrote there in your small groups later today. So please make sure you don't delete those. Okay, all right. So far you've noticed I've done #1, #2, #3. Those are the most important. Like #1 is the most important. That's called a problems-based note. All right, but there's also systems-based notes, and you can realize, hey, sometimes, okay, well. Problem-based notes, you're going to put problem number 1, which is most important, and sort of provide your rationale, then give the plan. Problem 2 all the way down, and then, as I was saying earlier, you can have FEN prophylaxis and whole person care and dispo at the very end. And you can see this is sort of like the most active problem is listed first. So when you say #1, it's this. That will tell everybody else that this is the main reason why they're in the hospital. Okay. Now sometimes people get a little bit more complicated, and you have to use a systems-based. So here you might say like, oh, okay, systems-based means I just go by pulmonary, and then the problems that fall under pulmonary, or cardiovascular that fall under cardiovascular, and GI, things that fall under GI. And you'll notice there's a whole boatload of systems here. Clearly you guys went through a lot of organ systems to get here. And you'll notice at the end, it still has FEN, whole person care, dispo there. But you really only have to list your the active symptoms, which means like you do not need to have every system listed here. So we'll practice that in just a sec. Okay. Okay. All right. So which one do you use when? Problems-based? If it's a relatively straightforward patient or a simpler patient, you're going to be using it. So for the most part this year, you're going to be using problems-based notes. Okay. But sometimes if you have a complex patient where there's just so many things going on, like let's say you have 20 hashtags, after a little while, it just sort of like starts to get crazy. And I'm not kidding when 20 hashtags, by the way. You might say like, okay, I'm going to start grouping them into systems. And how you group them in systems, is there's no exact art to which system. Like you might say, does pneumonia fall under infectious disease, or does it fall under pulmonary? It sort of is both in a sense. And so there's no right or wrong in how you do that, as long as you just keep it by system. So and so usually a lot of times during 4th year, you're going to have your ICU patients be systems-based or just really complex patients. Okay, so all right, so yeah, I'm going to give you 3 minutes now, and I'm going to have you just rearrange your morning progress notes so that's a systems-based assessment and plan. Because sometimes attendees will ask you for systems-based, and I do want you to practice it for just a few minutes. So
system-based, yeah, so like referral based, right?
All right. Okay. So hope you guys all had a chance to do that. And literally, you're realizing actually, I really am just rearranging stuff. So I'm not actually necessarily writing something new when I'm doing systems-based assessment plans, right? I'm just rearranging. So we'll just take a quick look here at like, like with the systems-based progress note, you're still going to have an assessment. 86-year-old male with history of hypothyroidism presents now with throat pain, dysphonia, weight loss, now with laryngeal cancer. Right, so you're like, okay. Or you might another way to write the assessment. Once again, you're going to see there's a couple different ways here. Now with likely malignancy, awaiting FNA biopsy. So your assessment plan is the same here. But then on your plan portion, you start going, okay, well, I'm going to put it in, maybe I'll put in ENT first, or I might put, something like that, or and laryngeal cancer, right? We already said you already wrote this portion down. You just now lumped it under the ENT category system. And let's say you throw hypothyroidism in there since that's your throat related stuff too. So you can see where problem number 1 and problem number 2 under ENT is maybe that system. And then HemOnc has a system here. You might even put under HemOnc, you could even put HemOnc and put laryngeal cancer. So you can see it fits in a couple different categories here. You might put anemia as well here. You don't need to put other stuff because there's not other things going on. You might have a nephro section here because acute kidney injury now, trying to feel intrinsic or pre-renal, post-renal, some of those things, but you'll notice after that, you don't have to put in a pulmonary category or a cardiology category because you're not addressing anything actively there in a sense, right? So you do not need to list every system. You just need to list the active systems and how you're organizing it. Okay, so then FEN, whole person here, and dispo still at the end. So whether you do a problems-based or systems-based note, you can still end it with these 3 things and be fine, right? Yeah. Okay, so your final systems-based assessment and plan might look like this. And you're like, okay, I think you guys got that, right? So you see how some of them have 2 things in there, some of them have 1 or none. So, and once again, even with system space, for the most part, you're still going to put the most important system at the top, which you think is going on, unless you're in that medical ICU, which pulmonology always likes pulmonary first since they're pulmonologists. So, okay, what do you do if you don't know, right? Like this is all fine, but like I'm not sure about a lot of things here, and that's okay, right? Like I hope you ask like a lot of questions during 3rd year and go like, I don't really know, so I need to ask to find out, or I need help here in a sense. And so the first people to ask always are your senior medical students who are on with you, or your 3rd years who actually are going to be on with you. So, but your residents are also obviously an awesome resource there. So, so ask your residents for feedback on your assessment and plans. So Dr. Tarver covered some clinical applications from this morning. You might have some online calculators to use. We talked about UpToDate, Dynamed, Sanford Guide, visual diagnosis. I know he brought up each of those a little bit. But like I mentioned these things here because I was just talking to somebody after the interprofessional education stuff on Wednesday, but I wouldn't necessarily cite, oh, Amboss told me to do this, so let's do this. And more because that's more of like a resource in a sense, or I had a world question, we should do this. We should, do that. So that's fine for you, like as you're just doing it for yourself. But if you're trying to defend yourself, like this is why I want to do what I want to do, you do want to use the resources that are out there in a sense. And then so once again, like you already had Dr. Estes and Dr. Green yesterday sort of talk about feedback and just like what it looks like to ask for feedback. And I think it's like it's when people give you real feedback, I think that's the best thing in the world, because like there's no other way to get better than to ask for feedback, right? And so when people actually care enough to say what you can improve on, for me, like it's easy to start going, is this personal, or is it actually something that like I'm going to get better at? And then Dr. Cardenas talked to you guys a little bit about self-directed learning, and this is, I mean, like to be up to 3rd year, sort of the last year of your life where people give you something to read. on the clerkships. But after that, you're just sort of learning everything on your own, like, and you have to look it up yourself and try to like feed yourself in that way. And so, so part of third year is just transitioning you off, like, these are the set things I'm going to use to, like, I gotta go find it for myself somewhere in a sense. And what was it? I had to look up something yesterday, but it's okay. I don't remember. Okay, clearly, but I'm always looking stuff up every single day for my patients. So, all right. Talked a little bit about style here. You know, it's better to err on the side of being thorough rather than being abbreviated. All right. So when you think about it, you're going to write more than 100, 1,000 of these notes in your career, which is sort of crazy when you think about it. You're actually going to write more than a couple, maybe more than 100,000, probably like 200,000, 300,000 of these notes. And yeah, I don't know, like part of me is like, you know, even like hope, you know, we're really hoping that a lot of your notes will be able to count for this year. But even if they don't, you're gonna have to like get good at writing them because you'll write so many. And then once you start writing your own notes, you just get faster at it. And maybe that's the easiest way to say it. So you'll learn a lot quicker. So, and then yeah, you'll also start to go like, I don't like writing a bajillion things every single time. So you'll start to know what you can cut out without like sacrificing quality in a sense. So I will be honest, if your notes for those of you whose notes don't count, you know, I'll be honest, a lot of times nobody's gonna read all of your notes, and that's okay, right? Because like nobody's got time to read all the notes. You'd rather them not just read all of your notes, you'd rather them like, you know, get their work done, be able to teach you, take you along as an apprentice for everything else you're doing. But you know, like you can still write a lot of your own notes and start comparing your own notes to the ones that everybody else is writing and going like, am I actually including the things that I need to have or not? Okay, all right. So now let's say you're this ENT surgical consultant, right? You've just been consulted, you're on the other side, and it's your turn now to actually write a consult note, right? So like in the past, I've gotten feedback from students, hey, I'm starting with some surgical specialty. I'd like to know how to write a surgical note. And so this is your chance to take 3 minutes and write out assessment plan from surgical consult note side of from that point of view in a sense. So I have to go ahead and type that out, and should be the next page on your worksheet to be able to do that, and then we'll come together. All right. Okay, so we're gonna go ahead and finish off this portion here. So maybe your console note might look like something like this. Once again, your subjective and objective portion, you're gonna sort of do like we practiced earlier, but assessment wise, you might just say likely laryngeal cancer, hypothyroidism, plan NPO at midnight. We're gonna do FNA aspiration in the morning, and then maybe get a thyroid ultrasound. Okay, to continue levothyroxine, 25 mics POQ day. And I facetiously just put the little note at the bottom about interesting consult in a sense. So, but you'll notice this is actually much simpler, much quicker, to the point in a sense. And that's sort of like what you might write a little bit more when you're on your surgical services as compared to something else. And now that doesn't absolve you from actually taking care of like let's say you're the primary team, like you still want to take care of his AKI, right? Like you're not going to ignore that. But as a consultant, I'm asking ENT, what do you want to do with this laryngeal cancer? And this is their note that responds with that, right? So they don't need to address the AKI because the primary team is addressing the AKI. They just need to address the question at hand, which is the laryngeal cancer. Okay, so, and all right. Oh, I'm not sure why it's doing that. Okay. All right, so once again, this is not necessarily gonna write notes the rest of your life. But once again, we're trying to get you just to write your notes as much as possible. These are learning tools, your chance to write down your clinical reasoning. You're going to get better at this, trust me. The only way though is you're just going to write a lot of notes. And and this is, the more you write, the more you're going to mess up and more you're going to develop your own style. Like I'll be honest, like people, like nobody's going to officially always tell you write a note for every single patient you see. But my encouragement is to write a note for every single patient you see. Like, and if nobody reads it, that's okay because you still learned a lot, and it's going to help you with your presentation. So there's like multiple ways that notes can help you out here in a sense. So, and yeah, okay. So, like if you have questions, come and email me. You can watch. I have like the video series for this entire thing. It's a little bit different than what we have here. It's on YouTube. You can just watch it there. And then the QR code has all the slides and resources for you guys there. So gonna hook you guys up with like a break until 10:45, and then we'll come back for the presentations portion of the workshop.
Really quick, guys, we have a couple announcements before you leave.
Yeah.
There was a quick question, Dr. Wei. Are the students supposed to contact ENT or the specialist? Because you said you're waiting for ENT, I guess. So are the students supposed to contact the specialist?
Yeah, so let's say you're on the primary team. Let's say you're on the internal medicine team. Hey, we have to contact ENT for a consult in a sense. Usually, like the students are, in my mind, always welcome to like page or call or contact ENT. But a lot of times your residents will be doing that, and you're asking, hey, ENT, can you help us out with this adult with laryngeal cancer? Can you help us know if we need to do a fine needle aspiration? That's the question you might have for them. I'm not sure if I'm answering the question there.
Yeah, I think, well, so you might always make sure you touch base with your team, right?
Yes.
Is there anything I can do? Do you want me to call a consult, or do you want me to reach out? And I think that's okay, but you just want to talk to your team and see that they're, you're not double calling, because that really doesn't go so well with a specialist. So if you're getting 3 different calls from 3 different people and nobody knows that they contacted, so just touch base on your team and you'll delegate duties for the day. I think that's one of the things.
Oh, absolutely. Yeah, it's like and I have a little bit talking about roundsmanship and other stuff on the presentations portion. So yeah. Perfect.
Okay, a couple more announcements. So there was one student come talk to me earlier. I told you Jay Miller is going to be in his office. So he will be in the office in the afternoon, just so you know, and he's working on your specific issue. So you know who you are. So go see Jay Miller in the afternoon, please. Also, student finance. If you, for some reason, have an issue with student finance, they close at 12:30 today. So if you have to sew something up with student finance, I will excuse you from the lunch because you have to have that ready, right? But please, otherwise, go to your lunch time. So 12:30, otherwise they open at 8:30 on Monday. Finally, our Latinidad, do you want to make your announcement now? Oh, one last thing. I know we're not wearing masks right now, right? So this is nice, but as soon as you get into any clinical area, I just want to remind you, make sure you have a mask. So if you happen to be in a clinic, like they may not have mask for you. So you would have to bring a mask with you from home, grab some from the hospital if you need to do that. But I'm just very cognizant of that just as we're seeing some of our own, unfortunately, not to any fault of their own, but we need to make sure that we wear a mask in the clinic. I don't want you guys kicked out.
Hey guys, so Latinidad is so happy and excited to be able to gift you guys these Spanish translation cards that you guys can be using during your clerkships. So we have some hard copies over here. We have about like 45, and then we're gonna send out a PDF to everybody so you can have it on your iPads. Just a reminder, in no way, shape, or form can this be used as a translation service. So this can just help you better understand your patients, or if you're in a room and they're speaking in Spanish, you can kind of translate what they're saying, or maybe even show your residents and your attendings and be like, look at this cool thing I have. And it could help the patient population that we have in San Bernardino, Loma Linda, Florida, honestly, like all of the areas that we're going to be going to. So this was a labor of love, and we really hope that you guys enjoy these and you get to learn some Spanish and better connect with your patients. So it's first come, first serve up here, but the PDF will be sent out. So thanks, guys.
Oh,
Please come back at 10:45 sharp. Dr. Wei has some great things in the second half.
Thank you.
Thank you. Can I see, I don't know who the class pastor is. Could you come up? And then Kenneth, would you mind coming up, please? Just for a second.
Kevin, are you able to hear me?
Okay, guys, please start coming back to your seats.
All right, so welcome back, everyone.
One more minute, Dr. Wade. There's some people in the lobby still coming.
Okay, cool. Yeah, no problem.
Give them about 60 seconds. Guys in the lobby, guys in the back, tell your friends to come on in. Dr. Wade is ready. Right, Dr. Wade, thank you so much. Let's go ahead and get started.
All right. Okay. Let's do that. Okay. All right. Well, welcome back, everyone. If you do need I mean, it's the same QR code as before if you want the presentations workshop PDF. And all right. So, okay. Well, in part two, like I'm really grateful that Dr. Corderas lets me do both of these. And it's more because I do think they're really tied into one another. They help each other out. And so we'll try the presentations portion of this right now. And so maybe the context again, remember like where we are, it's Tuesday morning at 9 o'clock in the morning. It's time for rounds and one of your patients is up first. And the resident tells the team that you also took on, not only do you have Mr. S from yesterday, but you also have an acute pancreatitis patient that got admitted overnight that you're going to be presenting as well. So, and so yeah, the resident says, okay, you're going to be presenting that patient as well. That's the context for this talk right here. So yeah, oh man, I got to present two patients this morning in a sense. And so yeah, let's talk about, what patient is that? It's actually going to be, if you look on your worksheet, it's going to be page number 7. There's a sample case there that actually has, has the admission history and physical for this acute pancreatitis case. And in your life, once again, in your life groups later on, you're going to be presenting Mr. S. You're also going to be presenting some of this acute pancreatitis case as well. Just a couple different cases you can practice with, a couple different kind of settings in a sense. So hold on, sorry. All right, I'm super grateful that God's allowed my voice to hold up so far. So thanks for hanging in with me so far. So presentations, the big overall thing here is you're essentially just telling the story of the patient, right? If you keep it there, like I think a lot of people, at least for myself, we're really freaked out about presentations because I feel like I have to do a performance. And when I look at something as a performance, then I just start to freak out and like get really anxious and things like that. But when I realize I'm actually just trying to tell people about this patient I care a lot about, and I want to tell the story as succinctly as I can and as thorough as I can, then it really helps you take the focus less on how do I appear and more about like how am I sort of trying to convey things about this patient that I really care about here. So and it's an opportunity for you to invite the rest of the team that you're presenting to into the patient's world, and you're sort of painting this picture, telling a story, and yeah, so yeah, hopefully that's a helpful like mental picture there instead of like some performance on a stage. where you have to memorize all your lines or something like that. So, but as with any good story, there's usually a flow, right? Like, don't start with the end and then tell some, the climax and then, end with once upon a time or something like that. It doesn't quite work that way in a sense. So, there has to be a flow and a pattern, and people generally have a pattern that they're listening to your presentations in. And guess what? It's in the SOAP note pattern. That's what they're listening for in a sense. So, one last thing is just imagine nobody else on the team knows about your patient. And so you have to say things in a way that, like, if they had never heard about this patient, could they actually be able to determine next steps based on what you share? Okay. So why are you doing presentations? I will be honest, when I was a third year, I'm like, why am I actually doing presentations? The rest of my life, I'm not actually going to be presenting to an attending. I will only be doing that when I'm a third and fourth year med student and when I'm a resident. But the rest of my life, I'm just going to be seeing people, right? So why am I learning to do this? So number one, first off, it's your main interaction with the attending, right? Like, when you think about it, actually during third year, your most common conversation with an attending will be doing an oral presentation, in a sense. And their main way of being able to assess, like, how is this third year medical student doing, is listening to you present a patient. So there's that part. It's your opportunity to demonstrate your grasp of the patient and the knowledge that you have. But for me, I think the most important and long-lasting part of this is it's learning to communicate, learning to talk, right? To do medical talk, right? And so far, first and second year, I'll be honest, most of the time you spent time learning medical stuff all in your head, right? It's just sort of like, oh yeah, I have these things down in my head. This is how it works. Maybe I drew out a couple of things, but now you have to verbalize and communicate all that stuff that you have in your head. You have to be able to actually bring it forth and say it to somebody and have it make sense to them as you're saying it, right? It makes sense in your head, but like to be able to say it out loud. It's like you guys just had a little announcement about Spanish translation stuff, and it's one thing to have it up there, but actually to speak it, it's a different thing. And so you're learning to build a vocabulary, but then how does, like, that's what first and second year is, you got a ton of vocabulary. Third and fourth year is like, how do I actually converse with people about that vocabulary, and hopefully have a conversation with them, right? So yeah, and then you get a chance to teach others too. Like, when you share, like, hey, I would like to do this because this article said that, like, I think everybody else can go like, wow, that's pretty cool. Like, I didn't know that. And now you've taught something and you're not just a student in a sense. Okay, so how do you do a presentation? We already talked a little bit about like structure to your story, right? Like starting with the right, most people want, once upon a time to start their story rather than, or some other hook rather than some random thing. So, and I'll be honest, like, think about the last time, maybe it was this week, you were hanging out with your friends, and you just heard a story told really well. You're just like really engaged, you want to listen, but maybe there was a time in your life where somebody else was not telling the story very well, and you were just like started to tune out of it, right? Like, it's just natural when like the story doesn't make sense. You might say, like, just get to the point, or just like, I don't quite get what you're trying to say here. It's sort of painful to listen to this. So imagine if you don't tell a story like that, like your presentation, you can see why other people start to sometimes have a little bit of a hard time trying to follow what you're saying in a sense. So, but that's okay, right? We realize you're third years, you're still learning. Nobody's asking you for a perfect story, but they are asking you to recognize, like, what are the components of a good story and try to follow that. So, and similarly, we just said, hey, using the SOAP format, people will not be confused about your story, right? And but it's when you go out of order. I have people sometimes go like, the labs showed this, and then the physical is this, and then my assessment is this, and then but oh yeah, the patient told me their pain is gone, and my plan is this. And so you can see where like that's all over the place, as opposed to the patient told me overnight that the pain is gone, the vitals are stable, and the physical exam hasn't changed, there's no new labs back, the new image shows laryngeal cancer, and the plan, my assessment is this, and then my plan is this. You can see where there's like the way you wrote your note is similar to how you should present a patient. All right, so here are some elements of the format. Again, just a little parallel to like an actual story on the right side, where you sort of like say, oh, this is the classic story that I've learned growing up that makes the most sense to people, and then this is sort of my SOAP note on the left side, and how that looks, right? So I did include a little quick thing at the bottom here called a learning point, which is something definitely on pediatrics we're a big proponent of, but we also, like anybody else like who's in medicine, like if you teach something for a couple seconds, people always can learn because there's just so much to learn in medicine. So I think when you share a quick learning point and you cite some evidence for that, or just like, hey, you guys all will read like articles or other things like on your patients, and just like, yeah, you might say with acute pancreatitis, like, new evidence is showing that you may need to start doing some genetic testing if they have recurrent episodes. Look, that took me like literally like 4 or 5 seconds to say, but something I read overnight, and it taught some people that, like, hey, we don't traditionally do genetic testing, but now we are starting to look at that a little bit more closely with acute pancreatitis or so. So that's just a learning point there. So, but yes, you'll know subjective, objective, assessment plan, all the things we just already did. Maybe one more thing here is citing evidence. Like when you decide to do, like, I want to do this, like, like the most maybe authoritative way to say that is like, hey, I read an article that said acute pancreatitis, recurrent acute pancreatitis, we should start checking, like SPINK1 or something like that. I know that doesn't make sense right now, but it's sort of like, as opposed to like, maybe we should do genetic testing. You see how like there's two, that sounds totally different to who you're suggesting things to. The first one says, I'm a self-directed learner. I look things up. I would like to do this. This is my plan. The second one is, I don't actually know what's going on. I'm not really confident of what I want to do. And can you decide if we should get genetic testing? That's how the second one comes across to everybody else. So, so just in terms of your presentations, a helpful thing is just to like say, I would like to do this, as opposed to, can we consider doing this? Because that one, just the way I just said that says somebody else will decide for me, right? As opposed to, I have decided this. Now some of you might say, like myself, like, I don't know what I'm doing here. Why should I be confident about something I'm not unsure of what I'm doing? But it's more like, no, you did read something and you are suggesting something, and this is what you would like to do. But like, nobody has to do that, right? You're just putting your thought process out there, and you're willing to put your neck out there to like for something, as opposed to letting someone else decide for you. Hopefully that part makes sense there in terms of like, so if you strike the word consider from your vocabulary, you're probably going to be a better third year as a result. So, okay, all right, that's a side point. I digress. But what are you trying to convey in that presentation? How are you going to go about that? Hopefully I'm really emphasizing structure here. Like the SOAP note structure, like will get you a far way in terms of presentations. It's easier said than done, but you literally, if you just start with the overnight events, then you talk about the vitals, the physical exam, talk about the labs after that, say, this is my assessment, this is my plan for this assessment, you'll be fine. And then you close with learning point or something. Okay, all right. I already said in the last hour that, hey, you really want to focus a lot of your energy on the assessment and plan portion. So, like, you can spend a lot of time gathering all the data, all the numbers, and you need to do that. But don't spend the majority of your time or even your energy saying the vitals are this, and that. Like, really try to like, everybody's really listening for your assessment plan. All right. And yeah, anybody can talk numbers. It's just more like, what do those numbers actually mean? So I already said organized and complete, right? Like, you're going to watch a lot of residents present very fast. They might, and it's okay to, like, you're saying that's me in a couple of years, but me right now needs to like try to communicate as completely as possible. And then lastly, pertinence, pertinent positive, pertinent negatives. Everybody will always say, hey, make sure you present pertinent physical exam or pertinent, labs and stuff like that. So I'll be honest, it's hard to know it's pertinent up front, but as you practice more and more, you'll get there, right? So like let's say for my for our laryngeal cancer guy, like a pertinent positive is everybody's wanting to know what your HENT and neck exam is like, but they may not care as much about your abdominal exam, right? So you don't need to say abdominal exam for this patient was soft, positive vowel sounds, non-tender, non-distended, no rigidity. It was, like no CVA tenderness. Like, people don't really need to know all of that because nobody cares about CVA tenderness in a guy who's got, neck cancer, right? So those would be pertinent those would be things that you don't need to mention as much, if that makes sense. Okay. All right. In terms of when, like, I guess I'm just going to the what and how and when, but for the when, it's sort of like, you know, on medicine and pediatrics, you're going to have like, you know, formal presentations. You're probably going to get about 5 minutes for a new admission H&P and maybe 2 to 3 minutes for subsequent daily progress note or daily presentation. These are like really rough timelines. You know, maybe on surgery, you have to be faster than that. And it's more just reading or just asking the residents, like, how long, you know, do people typically expect this to be? So, yeah, once again, just rough parameters help you out. All right, so gotta practice. I think the best way you can do this, just sort of like, you know, before I give this presentation talk to you guys, I'm always practicing for myself, like, how am I actually going to present stuff? Because it makes sense in my head, but like actually getting it out sounds a little bit different, right? So I think practice allows you to keep on going. Like if you know what you're going to say, you just practice, and you like give that it, you know, then when you have something to say, people don't interrupt you. It's when you don't have anything to say, or you're sort of like jumping about, skipping about, or when you're sort of like not sure of things, that's when people start saying, oh, you know, like they might interrupt you. But maybe the goal for you starting off is like be able to practice your presentation so that you can give your entire presentation without being interrupted. Yeah, you'll have some, you know, the best, you're like, when am I going to practice? Number one, the afternoons, like, you know, sometimes you might, what am I going to do with plan my afternoons? Well, practice presentations, that's one thing. In the morning, like, you know, just getting in with enough time to be able to pre-round on your patients and then also be able to practice some of your presentations is another thing. So, yeah, so I'll be honest, if someone interrupts your presentation, it's not always like, maybe they have like time pressures they have to get through, or it's not always you in a sense. All you can do for your standpoint is like, try to give as smooth a presentation as possible, right? So, and yeah, so once again, different attendings expected different ways. It might be a little frustrating at first. You're like, why do all these different attendings have different expectations for what I do? And why do I have to adapt to every single attending? That's really tiring. Like, I wish I could just do it one way. Well, to be absolutely honest, every patient is also very different, and what patients expect out of you will be very different as well. And so it's always being able to read the room, be able to adjust things and adapt to sort of like how things are, while still realizing every patient really wants you to take really good care of them. And every attending will want you to be able to really know your patient. So there's certain things that are always going to be like givens. It's just more like, you know, what they actually want you to do with that. It can be a little bit hard to tell at times, right? So, so you might say, like, I'll be honest, I say that because it is frustrating for a lot of third years. Like, I just wish somebody would tell me what they want done. And some people will tell you better than others. But at the same time, there are universal ways to tell stories that everybody appreciates. I mean, you know, just, you know, imagine Disney or Pixar, they tell stories well, right? Like, you know, like, and so if you are able to focus on elements of storytelling that are really done well, then you don't have to worry exactly about like all the smaller things as much. So I know it's easier for me to say that than actually, but so, okay. So, and now, like, I've done a lot of talking there.
Dr. Wei, really quick before you go on to
Yeah.
the, there was a question, and I apologize if you made that. I was answering a quick message here from someone else.
Yeah,
Should
yeah.
Always do research on a treatment before you suggest its use. So should you look up something before you mention it in your plan, maybe?
Yeah, so you're not going to have like time to look up everything, but of course, you know, as Dr. Gorin talked earlier about self-directed learning, you're trying to read as much as possible on your patients. And so yeah, as much as possible, you want your plan to be based on what you've read. Absolutely. But part of it's going to be discussion with your residents, like before rounds, like, you know, like, hey, I wanted to, you know, make this pancreatitis person MPO. And the resident might say, well, actually, you know, the latest studies say you can actually just, you can start feeding them pretty quickly. You don't need to keep them MPO. And you're like, oh, really? Okay, maybe I'll change my plan. So my presentation, so that I say, let's start a clear liquid diet on this person. You might not have had time to read that right before rounds, but you might make a mental note for yourself. I'm going to read a pancreatitis article after rounds. So during rounds, you might say like, okay, I would like to start this person on a clear liquid diet. And in a sense, so that's an example where you may not have read, but you're still suggesting something because you talked with your resident, and that's going to be huge, right? Like your resident's going to be your real world check. What you read is going to be sort of like your foundational stuff and what you're going to start your plans based off, but you're going to fine tune your plans by talking to your residents, which also means talk to your residents not at like 8:59. Hey, I'm presenting in a minute. Can you tell me like everything I should do for this patient? It's more like maybe at like 7:45, like, hey, like this is my plan for the day for this pancreatitis case. Any suggestions or anything that you do differently?
I just want to reiterate that your residents may save you right before you present to the attending in the group. So it's really important if you can skip, and it's another point of feedback, and they love to give feedback and to help you guys, right, when you're doing your presentations. So they'll help prepare, especially early on. Hey, I was thinking about this, and maybe practically, or maybe there's a systems issue where that isn't going to happen, right? So I would love to get them this, and that, but then you realize they have no insurance or something like that. So it's always good to touch base with your intern. They can bring in some of these other competencies to help you out.
Absolutely. So, yeah, and I'm always like, like for me, this is the part of like when you're part of a team and everybody's helping each other out. The more you help your residents out and your interns out with stuff, the more that they're probably going to pour into you in terms of this. But if they're going to do all the work, then they may not be able to teach or review some of this stuff with as much as with you. So it's all like when you're helpful, they're helpful. It's a good way to do that. So yes, but they will definitely help you there. Yeah. Any other questions that before we practice here? But sometimes it's better just to practice. All right. Well, if not, you're gonna look on page, pretty sure it's page 7. And I'm gonna have you read that sample case. That's the admission H&P. The following page is the progress note. You don't have to read that one yet, but for the admission H&P, I'm gonna have you read that. And then I'm actually gonna have you pair up, and then one of you is gonna be attending, and one of you is just gonna be the third-year student presenting. And then, so yeah, so we'll give you some time to do that and then go from there. We'll actually give you 7 minutes to do all that. So we'll see. That way you can present. All right. So I'm gonna bring it back together. Even if you're not done, that's okay, because once again, you're gonna practice some more of this when you are with your smaller groups, with your life communities. And last year when we did it, that was a lot of fun, and a lot of practical stuff from your third and fourth years that are helping out with that. So okay. So yeah, maybe you'll notice a couple things, like you're right. So there's an admission H&P note right there that you're trying to present off of. You might notice a couple things, like as you did the presentation. Maybe like you probably may have struggled saying, like, which thing do I just read the H&P? Like, is that how a presentation works? And the answer is no to that, right? But you're still trying to figure out what do I actually present, so I don't just read everything. I have to cut some things out. It's really hard to do some of that on the fly, and I really want you to experience, like, oh yeah, it's not necessarily just a one-to-one translation there, in a sense. But maybe the one most helpful tip that others have told me about, that Dr. Tim Lee actually told me about that, like I'm sure others have as well, but is, if you notice, like I should put it down here, every abnormal finding can be translated into an assessment. If you remember that portion, that will help you out there. So during a presentation, you're going to be presenting, some subjective stuff, some objective stuff. And let's say you're in the objective portion and you start talking about the lipase was 3962, right? Somewhere there's a need for a lot of us, including myself, to say, to interpret that 3962 right there and then, right? So so a lot of students are, like, when they start reporting an abnormal vital or abnormal lab value, they're going to start talking about, like, and blah, 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 this and that. But it's really helpful for you to say, to a note, the lipase was abnormal at 3962, and then go on. And then when you get to your assessment and plan, then you can talk about the abnormal finding by making it into a hashtag/assessment thing. All right. So instead of saying lipase was 3962, and I think this means pancreatitis, like during the objective portion of your presentation, you might say lipase is 3962 during your objective portion of your presentation and say that's abnormal. And then when you get to your plan portion, you're going to say lipase was 3962. This person has acute pancreatitis, as evidenced by this elevated lipase level. All right. So do you see how, like, that changes how you present? Because instead of presenting and talking about an assessment in a plan in the objective portion, you're actually leaving it for the assessment and plan portion. Does that make sense? I realized that was a little bit convoluted, but hopefully, if you have an abnormal finding, you can just say, I will talk about it during the assessment plan. You don't need to say that out loud. You can just note it, and then when you get there, you can do that. So, all right, another example really briefly would be, like, let's say you notice the K is like 2.5, right? So you can just say, hey, potassium was low at 2.5 during your objective portion of your presentation. And then during your plan portion, you might say, for this patient's hypokalemia, I would like to replete, with potassium chloride or something. Okay. So, all right. So now I think last time I did this, the students said, hey, can you actually just give a sample presentation? And I'm like, okay, I don't mind, reading out the like, sort of giving you guys what an admission H&P presentation, oral presentation might look like, right? So, so let's say it's 9 o'clock in the morning. I'm presenting this new overnight patient. I might say, hey, okay, well, I have, Miss J, who's an 18-year-old female with history of obesity. She's coming in with abdominal pain. It's epigastric abdominal pain that's 8 out of 10. It's non-radiating. It's pretty constant. It's sharp as well. She does have some nausea and vomiting and diarrhea as well. And she's tried some acetaminophen, hasn't helped. And her last meal was sort of the day prior to admission. She had some fried foods with that. So, and then the pain came on a couple hours after that. She denies any, like, constipation and denies any fevers. And rest of her immune system is negative. She doesn't have any past histories, doesn't drink alcohol, and no family history of appendicitis. Doesn't take any medications other than acetaminophen. For objective, her vitals, she's afebrile, and her heart rate is elevated at 112, otherwise unremarkable. And her BMI is 43. On physical exam, she's in no acute distress. She is obese, but otherwise, her heart is tachycardic, and her abdominal exam, does show some epigastric tenderness and palpation, but she's got a negative Murphy sign, negative Robson sign, no rigidity, and no hepatosplenomegaly. Labs for her show a lipase of 3962, obviously elevated, and her complete blood count does show elevated white count at 17.5, otherwise unremarkable. Her complete metabolic panel is also unremarkable. Imaging does show an abdominal ultrasound that shows intact gallbladder, no gallstones noted. So for my assessment and plan, I have I don't know why it says 16 there. It should be 18-year-old female with history of obesity, presents with epigastric abdominal pain, nausea, vomiting, and diarrhea, now with acute pancreatitis most likely. The reason I think it's acute pancreatitis is because there's elevated lipase, she's got nausea, vomiting, and her epigastric abdominal pain that radiates to the back. But, it's less likely, but cholelithiasis is also on my differential because she is obese and has an epigastric pain, but the abdominal ultrasound doesn't show any gallstones, so that's less likely. And she's got a negative Murphy sign on physical exam. For another differential is peptic ulcer disease, since she has epigastric pain, but she doesn't take NSAIDs. She's not stressed out right now, and yeah, so that's less likely. So my plan for her for acute pancreatitis with the lipase of 3962, I'm not sure why she has it at this time. Some of my differentials that I remember could cause pancreatitis include hypertriglyceridemia, gallstones, alcohol use, or scorpion stings. Obviously, less likely gallstones since they're not on the abdominal ultrasound. So I'm going to start her on some IV fluids, get her some pain control with morphine, start some, I should have said ondansetron, which is for anti-nausea, and then I'm going to get a fasting lipid panel because I do want to check for triglycerides. For obesity, I'm going to get a nutrition consult for some lifestyle counseling. For FEN prophylaxis, I'm going to start on a clear liquid diet. And for whole person care, she does find her strength in her face, and I did offer prayer, and patient was receptive. For disposition, patients probably going to be discharged once her abdominal pain resolves and she's tolerating PO intake. All right, so you can see where I didn't read the whole thing, but I mean, I did follow some of it. And some of the times you're able to express and explain out loud a little bit more what you're thinking. And once again, most people will be listening for when you talked about your assessment plan. Why do you think it's acute pancreatitis? And why is it less likely these other diagnoses that you are considering, right? And then plan wise, maybe you could say, hey, I read an acute pancreatitis article, and since it's her first episode, we don't need to do genetic testing, but we are going to get the lipid panel because we want to check her cholesterol levels or something like that. So it's once again putting most of your energy there. But I think, yeah, any questions after I gave the sample presentation there, like things that you're like, I'm wondering about that. Oh, sorry. Dr. Cornelius looks like he's coming down.
So if there is abnormal lab values, a lot, how do you know which ones to kind of focus on and prioritize?
Yes. So just because a lab value comes back abnormal of let's say the potassium's 5.1, right? Let's say 3.5 to 5 is normal for potassium. Potassium is 5.1. You probably don't need to sweat that too much, depending on the context. And so when you're reporting, you're always trying to report labs that are pertinent positives or pertinent negatives. Once again, I know that's not easier said than done, but you can say, you don't need to report every single lab. That's all I'm trying to say here. You're going to report ones that you think fit in with your assessment and plan, your overall thing. Once again, you're trying to present a story and trying to convince somebody that this person has pancreatitis. And so you're going to be talking the lipase, you're going to be talking the white blood cell count is going to be up here. And so that's how you're going to explain that. If there end up being just a lot of other stuff, you're going to ask your resident, which ones should I not present of all these abnormals is probably a helpful way to ask that. Otherwise, you could actually go down the deep hole too. You're right. Yeah. By the way, you are realizing I'm actually giving you relatively simple kind of patients. I know that's tough. And so, yeah, I'll be honest, it's okay to just tell yourself when the patients are complex, you're going to struggle. I'll be honest, for a long time, I really, really hated complex patients because I was like, I don't get it. There's just too much stuff going on. I'm getting overloaded here. Then it helped me remember that no patient wants to be complex. They just happen to be complex. So part of whole person care for me is being able to say, I want to know everything about my patient and to try to like bring it all together for the sake of the patient, because that's ultimately what I'm trying to do this all for, is to be able to present this patient well to someone else so they can get the right care that they need, in a sense.
Dr. Wei, I apologize, I was out of the room, but did you answer this question? How would the presentation differ for a top percentile med student who would definitely get a recommendation from you?
Yeah, I think the one thing that that separates people really is actually when they talk about their assessment and plan, that they are able to actually give their differential and give the reasoning why they think it's a differential this and why not. So their clinical reasoning there will play a huge role. And then in the plan portion is actually whether they are able, like whether I can tell that they're, trying to read up and use evidence-based medicine and really trying to say like, this is what I want to do based on what I read. And that's something that will really help distinguish people. So, because I'll be honest, most of the time, this portion right here will actually already have been written by the resident, right? So, the simple thing to do is just to read the resident note here. So, in my mind, I'm like, okay, the medical student can read. I mean, that's not what I really care about, right? I really want the medical student to be able to tell me what they're thinking. And so when you're able to like reason through stuff and you're able to verbalize that, that's when I start going, okay, this person is really, really trying to wrap their head around this patient. And then when they don't get it, they're self-directed learners and they're looking things up and they're really trying to like come up with something here. And they're willing to risk something, right? They're willing to say like, I read this and I would like to do this. And even if they're wrong, an excellent med student is one that's willing to be wrong and willing to just put their plan out there after they've read and talked to their resident. And that's okay, right? Once again, nobody's going to do you're not going to say this is what we're going to do and everyone's just going to do it. Like clearly, there's filters and faculty and residents who are going to help you out here, but you're not going to harm somebody by just suggesting something, if that makes sense. So you have nothing to lose there other than just saying, I'm willing to be wrong. And when I'm wrong, I learn better. Like I will remember what I got wrong much better than what I got right.
I just want to add that 98% of you guys are going to give a very good history and physical, right? Mm-hmm. So you guys are going to be able to talk about the history, do a great physical exam, and then report that back. What have we been talking about? We don't want you to just be a reporter though, right? That's what Dr. Wei is saying, is when you actually get to, that's why we had 2 sessions on clinical reasoning. Do you think it was by accident? It's because this is what we want to see. This is what we're trying to get you to that next step, right? Not just saying, here's the problem, right? How do we fix it, right? Always, we want to be thinking about the next step. There was a question over here. So if there's a patient that's been there 2-3 days, what if they've been there for 60 days, right? You're going to see some of these patients, right? And there's a plan already established day by day. Do we want to add something to that plan, or do we want to make adjustments to it? So Dr. Wei, what do you think?
Yeah, I mean, if the person is just waiting to go to a skilled nursing facility and there's nothing changed different, you're not going to like go through the whole presentation again, right? Like you might talk about the things that are different that day. You might say, hey, I talked to case manager today. It looks like the update is the skilled nursing facility will take them in 2 days instead of the week we were thinking. So you don't need to necessarily go through all of that. But that's more of a specialized circumstance, and you'll learn to like when to elongate your presentations and when to shorten them. But that one you obviously would shorten because everyone sort of knows there. But at the same time, I always try to remember like that patient is number one looking forward to going. But like that person's still a person, so like still talking about who that person is and remembering that they're still a human that you're taking care of there, rather than just a number to be dished off to somewhere else. it allows you to be able to talk about them like, hey, like, and you might just say, like the daughter's coming in today and we're going to update her on the plan or something like that. So just things that are still personal, you can still present a couple of things on that.
And I would just add that it's okay to come up with new things that maybe your resident hasn't had on their plan from the day before. I actually think it's exceptional, right? If you were to find something new on a patient that's been there for, several days, right? What if you're the person that comes in and says, hey, that makes a huge difference, and your residents and attendees will love you. I mean, even if it's a person that's been there 60, 90 days, right? I was talking to a nurse today, their decubitus ulcer seems to be getting worse, right? I know we haven't been mentioning that. Is that something that we need to talk about, right? Right. So that's actually a big deal. So that's something that you can bring up in round, something that you can mention on your notes. So don't be afraid of that. At the same time, we talked about that a little bit earlier. You don't want to show up your intern or resident like, you didn't catch this, right? Don't ever do that. You don't want to surprise your intern or resident too. Talk to them about it first. Like, hey, I notice in your notes, I don't know if this is important or not. Come from a very humble, and just like Dr. Rockstead talked about, right? Humility. I don't know if this is important or not, but I just want to let you know I found this. Okay. And I think they'll love it. Yeah.
Yeah, excellent point. I mean, the best way I always think about it is like when you work as a team, you want the best for everyone. And yeah, it's not about like one-upping anyone or anything like that. But yeah, you don't want to unintentionally one-up anyone either in a sense. And I hope the residents aren't going to be like, one-upping you either in a sense. So.
Dr. Wei, is it better to be longer time-wise with more details or shorter with less details? Oh, you're getting into specialty specific stuff.
Yeah, that's very specialty specific. And I always say, like, is it better to write a longer note or shorter note? It's you're going to start off with longer notes and you get shorter. Like your goal is always to get shorter and to get briefer with presentations. But the best way I think about third year is your year to be complete and thorough and everything. Fourth year is your chance to get efficient and briefer in a sense. That's very broad strokes there. So yeah. The tough part about third year is everyone's really rushed, and so you're going to have to get better at presenting faster. It's okay to start off longer. And then you're asking feedback. Hey, how do I make that a little bit shorter? Like, well, next time you don't need to mention every single lab value from the basic metabolic panel. You're like, okay, cool. That will save me like 10 seconds next time. That's how feedback works there. All right. So I did ask some fourth years, like, what do they wish they knew before you like when they were back in your shoes? I think the biggest thing is not taking things personally. I think Dr. Green and Dr. Estes talked a little bit about this. Like when it's so easy during third year to like think like there's something wrong with me. No, I'm super excited you guys are going to be starting. There's nothing wrong with you guys. You guys are just like doing something you've never done before, and so and it's, I don't know, like you guys want it, and that's really cool, right? So when people give you feedback, it's not because they think you're a bad person, but they think like, hey, this person actually could get a little bit better, like, at what they're doing. So I always go like, when people tell you what you're doing, like that you could correct, like I always just rejoice. At least I try to mentally rejoice, because I'm like, that's the only way I'm ever going to get better, is if somebody tells me like what I can do better, right? So and I love medicine because it's immediate feedback. It's not like, you start this week and then 6 months later you get a whole huge report of everything you've ever done wrong. You're like, but like every single day you're going to find out like, what did I do right? What did I do wrong? And I get to correct that, and I get to practice again tomorrow. And then the next day, I mean, like, talk about like getting better quicker. So yeah, so just not taking it personally, like, like they don't hate me. They just want me to get better, but they said something that hurt me. Well, no, actually they said something about my presentation that they didn't think was as good as it could be. So, okay, I can work on that. So, yeah, so that's how I try to think. And if you don't take it personally, then cool. And once again, it's okay to be wrong. It's actually expected for you to be wrong, right? Like if you're never wrong, then you're not trying anything, in a sense, because like, yeah, you do want to put stuff out there. So, you will get a lot of feedback, and that's entirely normal, right? Like, like when I think about the real world, if like, like every job out there gets performance evaluations. It's not because there's anything, people have anything against you guys. It's just more like, hey, it's really normal for people to get feedback and to get better at what they do. So, and then lastly, they just said, like in the midst of all this, it's so easy to think about the getting the note just right or the performance just right in a sense. Once again, but if you reframe it once again and say, it's not about a performance here. My oral presentation is really telling people about this patient that I really care about a lot. And I really want them to get the best care possible. And one of the main ways I'm going to get them the best care possible is to be able to talk about this presentation in a way that humanizes them, helps them know there's a story, and really says, this is what I want to be able to do for them. And I will be honest, like when you realize that privilege, it's so huge. And it's also more like when you tell the story of people, like it gives you compassion for them. And I'm finishing off Compassionomics right now, literally like the last chapter. The best way to prevent yourself from burnout is not seeing less patients. It's actually having compassion, more compassion for your patients in a sense. And for me, that's really empowering and impactful for me to think about, like, you know, presentations is one of the ways you develop meaning in medicine as you tell people's stories. So, okay, all right. Now, in terms of daily progress note, like this is just sort of like, you know, the next day, let's say it's the 9 o'clock, it's the following day or something like that. How does your daily progress note or daily presentation look different than your admission presentation? There's maybe a couple of things, you know, maybe like ins and outs are now part of it. And you're going to report some changes in the lab. So if you look at page 8 right now, if you look at the progress note on page 8, you'll notice like it's actually it's sort of shorter in a sense. Like the subjective has just the stuff overnight. The objective has the vitals, ins and outs, which I just mentioned in a physical exam. Once again, you know, this is a note, right? So you don't need to present the entire physical exam. Maybe at the start of the year, you're going to present more of the physical exam, but as the year goes on, you're not going to present every single thing on the physical exam. Lab-wise, you'll notice, hey, we did get this lipid panel back and the triglycerides came back at 893, right? And so in your assessment and plan, you'll notice like the assessment no longer has the differential there. And so, yeah, the next day you can say, like, let's say I'm practicing the progress, the daily oral presentation here. Maybe a 18-year-old female with history of obesity presents with epigastric abdominal pain, nausea, vomiting, and diarrhea. Now with acute pancreatitis secondary to hypertriglyceridemia. And so my plan for her is to continue just with the pain control for number one, acute pancreatitis. It's improving, and it's most likely due to hypertriglyceridemia. I would like to continue on IV fluids and continue the pain control. And then for the hypertriglyceridemia, I'm going to start fenofibrate, 145 milligrams. And then for obesity, I'm going to follow up with a nutrition consult. And then for FEN, I'm going to advance her diet to a low-fat diet as tolerated. And then whole person care, you know, she's continues to appreciate prayer. And for dispo, you know, like when she's tolerating her food and her adult pain, it gets better and she's off fluids, I think she can go home. So that's how you might present the next day's daily presentation in a sense. I know I went through that really fast, and that's okay because you will get to practice again in your smaller groups here. So a couple last thoughts here. Various ways to present for presentations. Students
really quick, I apologize, guys. This week has been different because I'm having to go back and forth between the old juniors. I need to go talk to them right now. I just want to say you guys are awesome. We're praying for you. I'm going to have your class pastor pray you guys out when you're done here. And Dr. Wei, we thank you so much. But I just want to say, if I don't see you in the afternoon, we're here for you, okay? So God bless you guys.
Yeah, thanks, Dr. Gomez. This is a lot of work this week. As somebody who's done this for the last 5 or 6 years and seen like different iterations of this week by far is like the most like hands-on practical, like you will go into third year with skills to actually be able to do a lot of stuff. So I think Dr. Gomez did a great job there. So but yeah, so some students say, hey, you know, like how do I actually prepare and actually do the presentations here? Like, do I write everything down by hand? Do I just like populate it on Epic? And to be honest, like it's your style, like whatever allows you, and you're gonna trial it in a couple different ways. Like some people just like to write everything down in the morning. Some people like, well, I can just start a note and everything pre-populates, and I'll write a couple things I'll present off my iPad. You know, like there's quite a different way to do it. So just mess around with that for a little bit, whatever's more natural for you. One thing that's really important is have your residents show you to print a team list, and that's more just so you can have all the patients on the team. How to be a best team member? How can I help you? Is much better than is there anything else I can help with? let's see, flow. Yeah, I don't know. Like one great tip from Grace Gilman is when you have that list for the whole team, like, every day at the end of rounds, your team has to execute on a lot of different things. So during rounds, the best way to track with things is just to track with just like put little check boxes with all the things you need to do for the day for all the different patients. And so instead of saying, is there anything I can help with? It's more like you let your resident know, I took care of this and this for this patient. Can I take care of this thing next or something like that? You see how that's a very different way of operating as a team there. And then people will help you get through third year together. So yeah, when you help the residents out, they'll help you out too. So, okay, there's a couple more things to go here. Once again, the QR code has everything in here. It also has an oral presentation guide by Danielle Hamilton and Chris Sellis, which will be really helpful for you guys too. Once again, this whole thing is on YouTube. There's a MedEd article on SOAP notes and presentations that might be able to help. But before, I'm going to have you guys just take this, do this quick evaluation so I can make this better. Like every year I make this better, hopefully, because you guys give me a couple minutes of just like, hey, what could I improve on? And then after 2 minutes, I'm going to go ahead and talk about how the role play is going to work and get you guys dismissed.
And then finish off.
I'll just post stuff on like Discord and send them an email. Just tell them to look up on it. I think so. I think we'll just go with Tuesday because we can still do it on Microsoft Teams. Yeah, regardless of they can access it. So, hey, are you going to announce about the elections, or are you going to share about the elections or not? So you can just give everyone a heads up too if you want, like. And then we can just send out an email.
All right. Well, thanks. And thank you everyone for just putting some quick notes there to help me improve. I really do appreciate that a lot. And so let me go ahead and close off in terms of the session here. So how does your role play going to work with your life group? So right, third and fourth years are going to be there to help you guys out. But essentially, let's say there's 8 of you, everybody will be student A, B, C, D, E, F, G, or something like that. But essentially, you're going to grab your lunch. You're going to go ahead and just like go to. I'll show you in a sec where you guys are all going. But essentially, a student's just going to practice presenting the mission H&P for the laryngeal cancer case, and everybody else get to watch a little bit and then sort of talk about like that case, and then maybe somebody will present a daily progress note. That way, you guys get an idea of how a daily progress note presentation might look different than an admission H&P presentation. And then, there's a couple more role plays. Once again, it's super up to your life community person to sort of like decide, but maybe you might want to present the ENT note real quickly. You might discuss some of the differences. And then there's also the acute pancreatitis case that we just had right there on your worksheet that you can present as well. And then if you have questions about outpatient, feel free to ask the third or fourth year about that portion as well, since those presentations might be a little bit different than inpatient presentations. Okay, and this is just for your locations where you're going to be going for whatever life group you're part of. And I just want to say thank you everyone for attending, and really looking forward to seeing you guys all on the wards.
All right. Hi, guys. Sorry, I have a quick announcement before we close out with prayer. So the Clinical Informatics and Analytic Interest Group is going to be hosting a EPIC tutorial next week, Tuesday, over dot phrases and how to kind of improve your note writing on EPIC. So just kind of stay tuned to Discord and email on the Facebook for more details for that.
Several people have been asking about elections for class office for the next school year. So we're gonna send information about that this weekend or next week sometime, if you're wondering.
All right, Kenneth is going to pray for you. I just want to read a Bible verse view to you. It says, "The Lord bless you and keep you. The Lord make his face shine upon you and be gracious to you. The Lord lift up his countenance upon you and give you peace." So may God be with you as you go into these clinical rotations. If you're still studying for STEP, may God go with you. May he give you peace, bless you, praying for you, and excited to see what he's going to do. Kenneth, would you pray for us, please?
Yes, sir. All right, let's bow our heads. Dear God, thank you so much for this opportunity to be here in medical school and to go through this journey with each other. And I ask that as we go into the hospital, into rotations and wards, that you would be with us and that you would use us in powerful ways, that you would empower us, give us good learning points, and help us to become better physicians so that we could serve others and serve you better in our future. In Jesus' name we pray, amen.